Welcome everybody. I'm Dr. Anita Kumari. I'm hematology oncology. I work at Valley Medical Center as well as in specialty health as a medical director. Thank you for joining us. Before we start, I just want to say thank you to every physician who has been working here day and night, making sure we are fighting COVID. And it looks like, at least for California, we are doing so far very well. I'm getting more and more reports from Valley and even UCSF that the curve is flattening. Just quickly, so this is a panel of, we have got everybody, infectious disease, pulmonary, hemonc, a lot of physicians together to kind of discuss the whole scenario in a specialty wise to see how much we can make everything go on together. Sorry. So just quickly before we start, this is going to be a recorded session and we will be putting this on YouTube. So just try to keep hospital stats or any information of the patient, just, basic minimum. It's all educational. Keep it to the point if possible, and evidence-based science. If there is any data from any published, scientific paper, please add that, and keep the answers short to the point. I will let Nidhi take over. Thank you so much, Nidhi.
Sure. Thanks, Anita. Hi, everyone. My name is Nidhi Gupta. I'm an internist by training, mainly working as primary care physician. I wanted to welcome all of you, especially the panelists. We all understand, you have a busy day. So thank you for taking the time and joining us today for this discussion. And like Anita said, we would appreciate if this is kept general because it's going to be recorded and on YouTube. So let's get a quick introduction from our panelists. I know some of them are familiar to me from last time. We have our pulmonary and critical care team. Can that team please introduce themselves? I think Dr. Subramaniam and Dr. Singh and Dr. Murthy are here.
Yeah, I'm Baldev Singh, Pulmonary Critical Care, South Bay.
Welcome, thank you. Who else do we have? I think we have Dr. Subramaniam today.
Yes. Dr. Subramaniam, Shyam Subramaniam.
You might be on mute.
Okay, let me unmute him. We can hear you, Dr. Subramaniam. Hello?
Maybe he will join back.
Hello?
Yeah, there you go.
Yeah. Are you able to hear? Okay.
Yes, now
that's better, yeah.
Yeah, probably a bad audio. So no, I'm a pulmonologist, section chief for specialty clinics for Sutter at Sutter Tracy. And I'm also with the ACCP. I chair the Clinical Pulmonary Network for the American College of Chest Physicians. Happy to be here.
Thank you for joining in. Did I miss anybody else from the pulmonary and critical care team, Anita?
Dr. Murthy is here too.
Dr. Murthy, yes. Thank you for coming back.
No problem. I'm on
intro.
call, so I might get pulled away. So,
okay.
Harish Murthy, Los Gatos Centers, a pulmonary critical care.
Welcome again.
Thank you.
Yeah, we have infectious disease panelists, Dr. Patel and Dr. Kapoor here. Please unmute yourself. Thank you.
Hi, my name is Minal Kapoor, infectious diseases. I'm new to the area, fairly new, moved from Chicago. So work in South Bay, basically Los Gatos and San Jose area, independent infectious disease.
Welcome, Dr. Kapoor. Dr. Patel? Did we lose Dr. Patel?
Let's see. Dr. Bijal Patel, so I'm going to unmute you.
This group as a recommendation of other parents who have kids around, and then also cycling care.
I think she's on another call, Anita. Let's
go ahead. Yeah.
Okay. So we have a hematology panel today with Dr. Agarwal and Dr. Ahmed. Can you please unmute and let the audience know? Introduce yourself, please.
Hello,
Yeah.
Hi, I'm Nasheen Ahmed. I'm currently a transplant and cellular therapy fellow at Case Western. I'm board certified hematology oncologist, worked at Cleveland Clinic before this, and I'm going to be working in University of Kansas starting July in cellular therapy and transplant.
Thank you so much.
Thank you for inviting
Welcome
me.
aboard. And we also have Dr. Agarwal, I think.
Yes, Dr. Agarwal is here. Dr. Agarwal, we cannot hear you. She is here. I can see her. Okay. Nidhi, take
All right.
to the next
We're
one.
going to move on to our radiologists. We have Dr. Rao and Dr. Arora.
Hi, everyone. Can you hear me? I am radiology, and I am from the South Bay. This is Archana Rao. Very happy to be here.
Thank you so much.
Welcome. And she's from one of our community,
Hospitals in the South Bay. Yes.
Yep. Welcome. And we have Dr. Arora.
Dr. Anurag Arora. Okay.
I saw him earlier.
Hi.
Hi, Dr.
Yeah, I'm not from the Bay Area. I'm actually in practice at University of Tennessee Health Science Center. We work in collaboration with St. Jude Children's Research Hospital as well. I am basically right now looking at the ER patients. So a lot of ER, that's why we in the last 2 weeks, we have started seeing the insurge of patients, and every day the knowledge is changing. So so it's a lot of difference. Last week, the things are different.
Welcome aboard. And then we have our cardiologist, Dr. Gudapati. I think I saw him earlier.
Here. Dr. Gudapati is here. Dr. Gudapati, hi.
Hi, I'm Surendra Gudapati. I'm a cardiologist. I'm an interventional cardiologist by training, but I do a lot of consults in the hospital. I practice mostly at El Camino Hospital here in Mountain View. And then I do take STEMI call at Valley Medical Center.
So you're everywhere.
But I used to go to other places, but now I'm primarily restricting to these two hospitals.
Thank you so much.
Thank you so much. Welcome aboard. So early in February, when we started seeing patients who were suspected to have COVID, or at least when I did, we didn't even know where to send these patients for testing, let alone how to treat them. So we've come a long way from there. Almost all the hospitals in this area, at least, are treating patients with COVID. And so I know that the initial treatments were based on protocols that were coming from China. Now that we've spent a few weeks using those protocols and we have some experience, I would, appreciate, especially starting off with our pulmonary panelists. Are you seeing any shift in the treatment? Are there any, support coming out to the existing treatment that we were using from China? Are you seeing something new that you guys are seeing in your intensive care units? Dr. Singh or Dr. Subramanian, anybody? We would love to hear from you.
Okay, it's too early to say really what particular specific antiviral therapy is working. When we started treating patients initially, end of February, beginning of March, we used in a few patients remdesivir, and it's really difficult to say whether it really worked or not. And then once the compassionate use went away, then we're starting to use Plaquenil and Zithromax. We have used IL-6 receptor blocker agent in one of my patients, but again, as far as whether there has been any shift or improvement in the morbidity of these patients with this specific therapy, it is really too early to say. As far as ICU care is concerned, and I can go over how we treat patients in ICU, or which patients end up in ICU, or which patients don't do well in ICU. We can talk about that. But right now, I think it's mostly, supportive therapy in ICU that, may or may not make a change in some of these patients.
So
I think the important thing is that, and we are looking at it at the hospital. Harish and I are working at is, looking very strongly with the administration to enroll, a few trials at the hospital, so that the IRB and our infectious disease specialists, collaborate and start any of these trials that are out there that are recommended by CDC, and specifically a few other universities like University of Minnesota, so that we can start these trials as quickly as possible, and maybe down the road see which therapy works or not.
is there a specific protocol that you're inclined to adopt as a hospital? Is it the convalescent plasma, or is it which one are we more interested in that we don't have currently?
Yeah, I think we are talking more about our infectious disease specialists are leaning more towards convalescent plasma. I think that's what we were talking about earlier this week in one of these administrative physician group, sessions that we have 3 times a week. So I think that's what we are looking at, and IRB is going to be looking at that as well.
And last week, we also touched on some of the testing parameters that were kind of give us a hint as to which patients are going to progress rapidly and end up in the sort of intensive care unit setting. Some of them, Dr. Murthy also mentioned, were a high ferritin, D-dimers, and I don't know, some hospitals are measuring IL-6. Is there a consistent trend that you've seen in your ICU patients?
Yeah, I think the patients who are older, patients who have diabetes, patients who have had symptoms like 3 to 4 days prior to coming in, and in the ED, if they have a respiratory rate like more than 30, if their saturations when they present are like less than 93, and if you calculate, do a blood gas, if you do a, like a PaO2, FiO2 ratio, if they are trending towards mild to moderate ARDS, that is their ratio being less than 300. And then you look at chest infiltrates, if they're progressing within 24 hours, these patients really don't do very well. They progress very quickly to where either the high flow doesn't work, and then you have to intubate these patients. But if you also kind of focus on some of the serum markers that may give you an insight as to which patients will get intubated, you look at the D-dimer, you look at the ferritin level, you look at the CRP levels. Lymphopenia is another one that really kind of tells you that these patients are not going to do well. And another factor of inflammation in the lungs is the LDH level. So there are a lot of things that one can focus clinically and chemically and kind of say, okay, this patient is not going to do well. So even though this patient may be looking okay, I think we should put this patient in the ICU and observe for 24 hours. And I think a few times we have, made that decision, and a couple of times I've seen where, borderline patients goes to a telemetry floor and overnight crashes and needs to be moved to the ICU. So I think we need to identify early these patients and then look at the markers and the clinical parameters that have been established or looked at in the literature, and put those patients in the ICU sooner than later, and then intubate them, sooner than later, instead of using other modalities. Plus, there's data that even awake proning helps in these patients. So, we can talk about.
Thank you so much. Dr. Subramaniam, are you here with us? Would you comment on the ARDS management currently in the hospital?
Is there any change?
Yeah, so I think what we are learning is this is a very atypical ARDS. There is publications coming out from Italy and also supported by unpublished anecdotal experiences being shared from New York and the UK that there seems to be a biphasic model for the respiratory failure here. So early on, it seems to be more of a shunt physiology where there is normal compliance, and PEEP may actually be harmful in that situation. And so in early on, depending on the mechanics on the ventilator, it is recommended not to actually use like an ARDS net protocol of high PEEP and low lung volumes and recruitment maneuvers, but instead focus primarily on improving the oxygenation status. I agree with Dr. Singh about the benefits of proning, and during this early phase, it is felt like the benefits of proning are not typically due to the recruitment of more alveoli as we normally see with ARDS, but due to redistribution of blood flow. But I think subsequently, once there is sort of a progression into much more classic ARDS, then then pretty much the management switches to a more traditional, increase the PEEP and get more recruitment of alveoli and that kind of a thing. So Gattoni from Italy has just published a paper sort of describing these two different phenotypes and clinically how we can make use of this information as for those of us who are pulmonologists or in the critical care unit to sort of look at the vent mechanics and sort of see, is this patient's lungs demonstrating normal compliance or low compliance? If it's normal to high compliance where the plateau pressures are not high, then avoid the use of early aggressive sort of PEEP strategy. So that is sort of one thing specific to vent management. Now, also agree with, to sort of add on to what Dr. Singh was saying, that one thing that is peculiar for this disease is these patients can look very, very normal and then deteriorate very quickly. And there is a disconnect early on between the serum markers, like if they have like, lymphopenia combination with high D-dimer combination with high ferritin levels, be very careful with those patients, because those patients can look like they're cruising along, no increased work of breathing, 2 liters of oxygen, and then 24, 48 hours later, they're just rapidly going down the tubes. And this is pretty well described both in the literature as well as other people's experience. And so those patients need to be monitored very aggressively. The early anticoagulation is recommended for those patients. So we typically tend to use early anticoagulation and combination therapy with antivirals as well as tocilizumab, which is the IL-6 blocker, particularly for those patients who have D-dimer levels 4 to 6 times above the upper limit of normal, along with ferritin and lymphopenia. And then, of course, if they have other risk factors for progression, elderly, COPD, underlying heart or lung disease, diabetes, that kind of thing.
So are you giving a single dose of the Actemra, the tocilizumab, or is that?
Yeah, so that's a really good question. So there's 2 studies that are currently in the literature. One of the studies used only a single dose of 400 milligrams of tocilizumab, and then another, that's sort of a subsequent study that just got published, suggested that 2 doses actually work better. So there were 4 patients out of, I think it was 15 or 19 in that paper that did poorly, and all those 4 patients who did poorly were the ones who only had 1 dose. So they seem to be suggesting 400 milligrams to be repeated in 2 infusions. So that is sort of what we are going with now. Obviously, I think one has to balance out that with if we in the future start running into limited reserves of medication, then we might have to sort of triage that kind of decision making to what is the availability of these agents as well.
Quick follow-up questions regarding the ICU stay with these patients. First is there sort of an average length of stay of these intubated patients that you're seeing? And then the second is, are there any parameters, patient demographics or biomarkers or wet markers that can kind of help you, you know, understand which patients are going to do better, like are ready to be extubated and, you know, being rolling out?
So the average length of stay, if the patients have really moderate to severe ARDS, is usually longer in my experience compared to the regular ARDS patients. For some reason, I'm not really sure why. Whether it's the phenotype that we are talking about, the later phenotype plays a part or not, or whether it's other comorbidities involved, like, you know, cardiomyopathy that's involved in some of these patients. Not really clear, but the patients, you know, tend to kind of have a PF ratio in low 100s. And they tend to stay like that no matter what you do, whether you prone them, whether you paralyze them, or use, you know, judicious fluid use or empiric antibiotics. It's not really clear. In our experience, they are on the vent longer, and meaning, you know, 2 weeks or so, sometimes, you know, closer to 21 days. And then the question actually becomes, you know, we have wrestled with this question about tracheostomy in these patients, but fortunately, you know, we have been able to extubate these patients around like week 3, close to week 3. Then we monitor them, you know, for several, you know, at least 3 or 4 days, maybe 2 or 3 days in the ICU, see what their FiO2 requirement is, all the other physiologic parameters, and you know, we repeat the COVID testing, and you know, if they've been stable for about 48 hours, then we have you know, transition floor, telemetry floor, where we send these patients to be watched very carefully. But in our experience, these patients, if they make it, they are on the vent longer.
Thank you. Dr. Subramaniam, have you noticed anything, any difference if you've had experience with any younger patients versus older patients? Is there a difference in the ICU stay and the duration of stay and the recovery?
No, I think certainly, as you would expect, I think younger patients do better. Elderly patients with underlying cardiopulmonary disease, they do poorly. Generally, they kind of enter into this cytokine surge or you know, acute deterioration on day 9 to day 10. At least that's what the literature also suggests, and then they, you know, that typically goes on for, you know, 5 to 7 days, and depending on, you know, how rapidly it progresses or not. But yeah, these patients are not going to turn around quickly, and again, the largest series we have in terms of the literature is from Italy, and they do sort of advise caution with the initial, any kind of initial improvement, to be cautious and be patient a little more than what we would generally be with these patients in terms of avoiding early extubation. Generally, our philosophy as intensivists is to, you know, try to be, you know, do daily SBT trials and try to really push for liberation from the ABCD sort of, you know, approach or protocol to try to liberate from the ventilator sooner. But here, I think just a word of caution in terms of high reintubation rates, and there is, we haven't seen it yet, but the literature does suggest that there is quite a higher prevalence of reintubation rates in these patients due to upper airway stridor and edema. And so that may be something just to watch out for.
Thank you so much. So I think I would next like to hear some from our infectious disease panelists. Are there any new, I mean, we always, every time we come here talk on Thursday, there's a new drug on the board. So now we have ivermectin. So yeah. Would anyone walk us through the current, you know, drugs we have on the table and which one we're going for, which one looks promising?
So First of all, we all should know that as of now, we really don't have a magic bullet, and there is no one right answer. Now, while we are still waiting for the clinical trials, we have to understand that with all the information that is circulating, we have kind of understood the trajectory of the disease. And so just talking about that, we know that the disease kind of goes in two phases. There's an early phase in the first 1 to 9 days where the patient initially has a fever. And so that part of the disease is more of viral mediated, while the latter part of the disease, which is generally about 10 to 18 days, which is the phase 2, may be more immune mediated. And so we have to kind of think about the treatments in these two phases. So phase 1, which is more viral mediated, we want to think about more antivirals with the remdesivir or the chloroquine or the hydroxychloroquine or the HIV medications, while in the phase 2, which is more immune mediated, we want to think more about the IL-6 inhibitors. So talking about all of those medications, I mean, the data is not very promising. As far as the newer medications or the newer data and ivermectin that you mentioned, and as we all know that ivermectin is currently FDA-approved medication for intestinal worms, mainly the strongyloides and the onchocerca. There have been some in vitro trials for ivermectin that have shown that it reduces the number of cells associated with viral DNA. And in some of the studies, it has shown that it reduces the viral copies by 99% in about 24 hours. But remember, those are just in vitro studies. So we really don't have any in vivo data right now. As far as I know, there have been I think there is one clinical trial that is ongoing for ivermectin, and I don't remember which one is in which country they are doing that. But mainly it is the protein. It is called the cargo transporter protein, and the virus needs this protein to get into the nucleus. And what ivermectin does is really it blocks this cargo transporter protein, which means the virus cannot get in the nucleus, and so the antiviral response can be maintained. We also want to make sure that we understand the side effects of the ivermectin, which mainly include could be severe headaches, dizziness, nausea, vomiting, muscle cramps, and aches. So what we are really waiting for is good clinical trials that really prove that ivermectin works. Because right now we have nothing but some in vitro studies. The next thing that was out on the horizon that has been talked a lot is the BCG vaccine.
Right.
The BCG vaccine, I mean, the whole concept about the BCG vaccine is that it generally boosts the immune system. And there have been observational studies that were published like several decades ago by some Danish researchers that showed that the vaccine prevents about 20 to 30% of infections other than TB. Now, in 2014, WHO, it showed that it does lower the overall mortality rate in children, but it rated confidence in the study as very low. And then there was another review that was done in 2016 that was a bit more positive about the BCG's potential benefits as far as reducing other infections. I know that there is a trial in Netherlands that is a double-blind control trial that is ongoing, and that is made to see if there is reduction of absenteeism in healthcare workers. So I think they are recruiting about 1,000 healthcare workers, and they are seeing the secondary outcome is really to reduce hospital admission and ICU admissions in the healthcare workers. So that would be something on the horizon to watch for. I know that Johns Hopkins, I think, is it Johns Hopkins that is doing some studies? There have been, it is the University of Melbourne in Australia. So they are doing some BCG studies on healthcare workers as well. So there are a couple of studies, good studies, even with the University of Toronto. But as of now, there is no proven benefit that BCG vaccine. I mean, the only thing is more of a retrospective, where there are countries which have the BCG vaccination, which is mandatory. They have seen that the load of the disease in those countries is less as compared to the disease where the BCG vaccine is not mandatory. So those are the two basic treatments that are on the horizon. That's something to watch for. And then the other things that we talk about a lot in these meetings is remdesivir. And as Dr. Singh already mentioned, that there are a lot of clinical trials that have been ongoing. I mean, for now to use remdesivir, we really have to be enrolled in clinical trials. The other that is overused medication along with the combination is really hydroxychloroquine alone or in combination with azithromycin, and that has been used extensively. There was a recent report, I think from April 7th, that there were some cardiology societies that just kind of posed a risk to make sure who we are prescribing these medications for. Especially we have to be aware of patients who have baseline QT prolongations of 500 milliseconds, or the patients with congenital long QT intervals. So you have to be really careful when you are prescribing these medications. So those were a few of the warnings that we want to make sure that they are just not used casually. And also we have to think about the shortages of these medications. And I know that FDA just recently posted some information regarding the shortages of hydroxychloroquine and chloroquine and we really want to make sure that we preserve these medications for patients with RAs and SLEs.
Sounds good.
Yeah.
Thank you so much for the detailed coverage of the drugs. Appreciate. Next question is to Dr. Patel.
Hold on, Dr. Shyam has a question, it seems. Dr. Sundar.
No, I just wanted to make a quick point about the antivirals. I think one thing we are forgetting or I see sometimes overlooked is that there actually is a benefit to lopinavir ritonavir. So I've heard Dr. Bin Chao, who is the lead author on the NEJM paper, he spoke on one of the ACCP webinars as well. And there's a lot of data in the sicker patients where there is reduction in the 28-day mortality, and it actually cut down the ICU length of stay by almost 50%. Like there was about a 54 reduction in ICU length of stay on the lopinavir ritonavir, even in the NEJM paper. So while the paper sort of was negative in the sense it didn't meet its primary endpoint, there was a lot of key clinically endpoints in the sicker population. So I personally tend to actually use that only because currently we don't have sort of the results of the solidarity trial, which is the triple therapy with remdesivir, lopinavir, and ritonavir and interferon. So waiting on those results. But until then, I think, at least to me personally, it makes sense to be aggressive with antiviral use because there definitely are very key clinical parameters that in a very well and elegantly done randomized controls trial have shown benefits. So that was the only point I sort of wanted to emphasize on. And then the other thing is we are starting to really appreciate the value of early anticoagulation, particularly in two settings. One is in patients who have excessively high D-dimer levels, and the second is those who manifest evidence of coagulopathy.
That's a very good point you bring up, Dr. Subramaniam, because that was my next question going to be, or one of the questions. I don't know which panelist would take that up, because there's these reports of these microthrombi and sort of a coagulation consumption kind of picture and some, antiphospholipid antibodies. And so we wanted to, know are we doing early anticoagulation, and is that of any benefit? Or are we mainly, is that more of an infectious thrombi related process, or there's value in adding early anticoagulation? Dr. Subramaniam, you just brought that point. Do you mind filling that in?
So I think that is a question that hematology would be taking on, Nidhi. If you're okay, we can put that on there. I think,
Dr. Ahmed, do you want to chime in?
Hello.
Yeah.
Yeah, so we've definitely seen a lot of thrombi, like macrovascular thrombi, EVTs, very high incidence of that, as well as microvascular thrombi. So like infarcts around the brain, the lungs, like even in the heart, like pretty much everywhere. So DIC definitely plays a role in that, microvascular as well as macrovascular thrombosis. But again, I think there's more to that. I think complement activation might be playing a role. The fact that we have these patients case where we found like antibodies, antiphospholipid antibodies, beta-2-glycoprotein antibodies. I mean, that's very interesting. We just don't know a lot about it. There's no consensus about when to start full anticoagulation versus just keep them on therapy on prophylactic anticoagulation at this point. But I think the hematology community as a whole feels like there should be a lower threshold towards full anticoagulation because it's a very thrombotic state based on the cases that we've seen. I mean, anecdotally, of course, pulmonology, Dr. Subramaniam, I don't know what your experience is, but that's what we've been seeing.
So if the question to the pulmonary guys, are you guys doing prophylactic anticoagulation or therapeutic anticoagulation? Because I think we have data more for prophylactic right now, but I wanted to know, are we doing therapeutic?
Yes, we are. There is at least one good paper on that suggests that there is a mortality benefit to early anticoagulation in using therapeutic Lovenox. And that is in two settings. One is with a D-dimer level more than 6 times the upper limit of normal. And Bin Chow's paper actually suggests to lower that to D-dimer levels of 4 times upper limit of normal. And then the other is whether there is something called the SIC score, the coagulopathy score with sepsis. If that score is more than 4, or if the D-dimer levels are excessively high, then you sort of should move to therapeutic anticoagulation. At least that's sort of my how we tend to do it.
Thank you so much. And since we're on the topic, I would like to, tag along with our radiologists. Are we seeing any of these, in radiology when we're looking at the peripheral infiltrates, when we're looking at the CT scans? I know the PE protocol is different, but are you seeing any more of these microthrombi in the imaging?
Anurag, you want to go first? I can take it if you want. Yeah.
Okay, so as of now, the protocol in our hospital, can you see me?
Yes. Oh, you lost the
We
video.
usually start with non-contrast studies, and that too when the pre-test probability is very high that this is a COVID patient and has in respiratory distress. And because the typical findings of ground glass haze is basically masked if we give contrast.
Right.
So for looking at thrombi, we need a contrast P protocol study. So what we have been seeing that when a patient's D-dimer levels are high, we usually do a non-contrast and followed by a P protocol, just to make sure that the patient is not having, pulmonary embolus as a cause of breathlessness, because it's taking 7 days to get a COVID test result. Mm-hmm. So patient is walking in with fever and breathlessness. Could be COVID, could be any other thing. Mm-hmm. So if D-dimer is high, we do 2 studies, like non-contrast. But as of now, we haven't seen any positive pulmonary thromboembolus along with in a patient who is tested positive. So it's a typical ground glass pattern which we are seeing right now.
How about the cerebral microthrombi?
No, we have not been ordering. So yes, we've read studies that patients are coming with strokes, but we have not been getting studies specifically angios to look for thrombosis. Okay. And what's Archana's take on it? Because it's a different setup.
Thank you. I'm going to just bring over a screen. Are you guys seeing this?
Yes.
Yes.
Okay, super. So I'm going to skim through the chest x-ray part because I think we're going to just go straight up to the CTA. So CTPA, basically, here's one. It's a very classic image. I think to first answer, Anurag's question, what has been our experience? We've actually seen, I personally have seen one case, and I know somebody had actually cited another case to the broader group. So we do have at least 2 cases that I can mention. So typically, our images don't usually look this pretty, but what we see is we see the anatomy being laid out. These are the main pulmonary arteries right here, these antler-like things that are coming off of them. Those are the lobar branches. And then further down, we have segmental and subsegmental. And so right here is a very classic one. It's almost a saddle. It's going almost into the origin of the other vessel, but it is a right lower lobe segmental branch thrombus. And then there's another little clot right there. I think this sort of leads into the whole discussion that you guys just had on DIC. So I'm going to skip that. But what I did want to mention is that basically, I think so far as our literature is concerned, and interestingly, we've had the first 2 cases. So there were 2 case reports that first came out in February from China, and was reported where they did see PEs in those patients with COVID. A few days later in March, they did a larger study on a much bigger cohort, and they had 1,008 patients, of whom 10 patients actually did end up having PEs. But they did see those in the smaller branches. They didn't see them in the lower branches. And the more recent study, that was just the only other article that I found is this one, a case report again from Italy. I'm sure we're going to be flooded with a lot more literature on this eventually. But yeah, so this is the first thing. And, you know, there's all this initial discussion of this being a single organ disease, but it isn't. We're now seeing, I think Nidhi mentioned it, and I think Anurag mentioned it as well. We do see hemorrhagic infarcts. We see hemorrhagic necrotizing encephalitis in the brain, also because of the micro thromboemboli that happen as a part of the disease process. So, yeah.
So are those being concomitantly ordered because of elevated D dimers or a specific clinical presentation? Can you talk about that, Archana? Or
sure. So we don't have a imaging paradigm at this point. Mm-hmm. So what our ED docs did, I think, for the last week that I was working, this week I've been off, but what they did do is when they had a patient who was having shortness of breath that was disproportionate to the chest x-ray, they didn't order just a chest CT, they ordered a CTPA. So yes, an elevated D dimer, I think, is definitely a pointer in that direction. But for the most part, we had patients who were being imaged when they had that sort of hypoxemia, shortness of breath, that was disproportionate to the chest x-ray. And I think the other thing I did want to just slightly touch upon is the fact that the chest x-ray is really not the most helpful imaging we have. I mean, here's a case, there's this, relatively normal looking chest x-ray, and then we look at the chest CT and we see some early ground glass opacities. So there is that, that caveat that chest x-rays are just not the most sensitive modality that we have. So Anurag, correct me if I'm wrong, but there's not a whole lot of support from radiologists for CTPAs. Is that right? I mean, we're saying don't do those if you don't have to do those. Actually, we're saying don't do much imaging unless you have a patient who's COVID positive and the patient is having moderate to severe symptoms, correct?
Yes, absolutely. This Fleshner Society just came up with a recommendation that imaging doesn't have a very big role in this, except that when you are, can you hear me?
Yes.
Yeah, so except that when you are looking to, in a moderately severe patient, when pretest probability is very high that the patient is COVID positive, yes, imaging does play a role. And specifically when a chest radiograph, most people who come in breathlessness, it's kind of mandatory, like they get a chest radiograph. And mostly you see a negative chest radiograph because the protocol right now is just order one portable AP radiograph. So when you see a patient who has a negative chest radiograph and your pretest probability of COVID is very high, then we get a CT scan. And if the D dimers are not high, then we don't get a contrast study. That's what is happening in my hospital.
So Anurag, isn't the D-dimer anyways very high, considering that these are probably in DIC as well? So probably
No, not always. Not always.
at
The
least the
dimers.
patients with all the. That's what I was thinking, that yeah, they are mostly in especially the ones that are intubated. So are you guys following the D-dimer for ordering the contrast CT, or you guys are just doing non-contrast CT?
So sometimes we do get a CT in a patient who's already admitted in our ICU and was admitted initially and did not have any imaging study at that time. So no radiograph, no CT, patient was admitted, went directly to ICU, and 3 or 4 days in the course, then the patient comes down for a CT. So that time, till last week, we were just getting CT non-contrast and to look for the crazy paving pattern or the exacerbating signs of ground glass haze turning into pneumonia or lobar consolidation. But we've not been doing a lot of contrast studies. So we, in my department, we've not been, maybe D-dimer is what the clinicians are following, and that's what we have discussed. What's Archana's take on it? How many patients are getting
Very few.
contrast?
Yeah, Anita, so specifically to the D-dimer issue, that's usually the trigger, okay? That is the trigger for most CTPAs when patient has, worsening hypoxemia for just any patient. It doesn't even have to be just because they have COVID. So yeah, that is typically one of the reasons, but it's a very liberally, very, very generously used study for a lot of patients that come through the ER. So we do have some strict regulations as to who gets scanned, but D-dimer is actually one of the triggers that leads to a CTPA. I don't think we do CTPAs on patients without elevated D-dimers.
Correct.
Yeah, that's what
we don't
do.
That's not true?
Yep.
Well, that's not true. Anurag probably says.
No. That's what exactly. We don't do CTPA if D-dimer is not relevant.
Yeah, got it.
That is absolutely correct.
Dr. Shyam has a point. Go ahead.
Yeah, thanks, Anita. I just wanted to provide a clinical perspective. I completely agree with the radiologists that the Fleischner criteria, the Fleischner, not criteria, but the recommendations are to minimize use of imaging in these patients, and I think it's very, very important for clinicians to sort of follow through with that. This is a very different disease than what we would typically do. Like usually in cases with respiratory failure, if we do see an elevated D-dimer, we may be sort of tempted towards ordering a CT angio, and in these patients, that is probably not what we should be doing. I think, as was already pointed out by our esteemed radiologists, that the main role for CT, and it is a very important role, is in the high pretest probability and negative first PCR. So there's over a 30% false negative rate for initial PCR. And if your chest X-ray and clinical features are suggestive, then getting a CT can really help you, because if you see those classic changes on CT, then that's helpful. Once a patient, and this was actually more useful in scenarios where we were having a delay in getting the testing done. Now that there is, at least in our center, we are getting the tests back very quickly. And so there's a very diminishing window of reason to do it just for a clinical suspicion, unless your first test comes back negative. We just had a patient where he had 2 negative PCRs, very suggestive CT, and then the third one, ultimately the PCR did come back positive. So that is a very different scenario. But once somebody actually has a positive PCR and is an established COVID-19, even chest X-ray used routinely is not recommended unless it's going to change management, unless there is like a major change in the clinical status or he gets much more hypoxemic. And I see very limited role, at least as a clinician, and I would encourage other clinicians also to limit use of CT unless it's really necessary, because these patients tend to be very infectious, and it's a big resource strain on the system to be ordering radiographic images unless you're going to do something very different about it. Very elevated D-dimers, we should not be doing, at least in my opinion, we should not be routinely triggering that as a reason to be ordering CTAs for rule out PEs?
So, the logistics behind not ordering enough of CTs is that the patients are too infectious and we do not want to keep contaminating our CT machine. If hospital has a portable CT, that's a different ballgame altogether. But portable radiographs specifically meant for COVID patients is what is happening in our. So it's a decontamination of the machine. Every time you scan a patient, you have to decontaminate the machine. That's a very big hassle right now.
Yeah, it takes a couple of hours. Thank you so much. That was very informative, everyone. And in the interest of time, we do have a question for Dr. Agarwal related to the antibodies, the convalescent plasma. Is Dr. Yeah.
Can you see me?
Yes. Hi,
Can you hear me also?
Yes,
because
we can hear you.
not able to hear me. So I actually have a comment upon the anticoagulation for patients who are COVID positive and the role of anticoagulation. So I do understand that they have elevated D dimers, they have a higher mortality, but I think I would basically put a sign of caution in these patients, because with the low platelet count and other coagulopathy, the risk of bleeding complications are very high. And if you look at the ASH guidelines, I just reviewed them one more time. They are recognizing that they are coagulopathies and also high risk of mortality related to clotting and microvascular clots. The routine use of full dose low molecular weight heparin is not recommended. Prophylactic use is recommended. And we also specifically recommend only low molecular or unfractionated heparin instead of oral anticoagulants such as Xarelto or Epeximum, because they do increase your cytokine levels. So that's there. There is a there is a report in New England Journal of 3 patients who actually became positive for antiphospholipid antibody syndrome. Most of the time, these antibodies are not necessarily correlated with clotting manifestations. These were beta-2 microglobulins, beta-2 glycoproteins, and mainly IgA type. Those typically are not associated with clotting issues. These clotting issues in these patients may or may not be related to antiphospholipid antibody syndrome. So I would say anticoagulate if there is an indication, if there is a PE, if there is a CVA or stroke, cardiac manifestation, but not just because they have a positive anticardiolipin antibody, that to IgA beta-2 microglobulin antibody.
Thank you so much, Dr. Agarwal. Actually, that's what even I read, that it should be prophylactic most of the time, unless there is a rare dire need of a full coagulation. So, yes. Would you like to comment a little bit on the plasma directed? There's a lot of data coming, plasmapheresis. I know we are not recommending that IVIG, but is there anything that we should think about? I know convalescent plasma is there, but anything else before we go there?
So I looked at the data. I did not get a lot of time to review every single thing, but there is an FDA mandate going on for a convalescent plasma protocol, and it's coming from Mayo Clinic is taking charge of it. So you can register your patient or participate in the clinical trial for convalescent plasma treatment. There are about 3 papers, all from China. There is one case series of about 10 patients, and then another one of about 5 patients who received convalescent plasma in patients specifically who had almost multi-organ failure, ARDS, or severe COVID disease. And it's a case report, it's not, or a case series of probably, if I combine all of them, about 20 patients. I wouldn't call this a clinical trial, but in all of those patients, there is an improvement in the outcome. They were able to shorten the duration of ICU. They were able to extubate them earlier on and lower mortality in patients who received convalescent plasma. And there is evidence from previous viral infections such as COVID, SARS-1 and MERS, and H1N1 influenza, where convalescent plasma did improve the mortality and morbidity in these patients, and specifically now that we don't have any treatment or antiviral drugs at this time to treat these patients. In certain patients where the need is severe, I think convalescent plasma can help. So Red Cross, and I think that there are about 5 blood banks which are actually helping with the convalescent plasma protocols. Usually a single dose of 200 ml of this one infusion is what is being studied, and it showed to be effective. And Red Cross is coordinating these events. So if you have a patient who may benefit from convalescent plasma, please reach out to Mayo Clinic, register your patient, register yourself and the institution. And they are actually making the guidelines and the restrictions very easy to participate. And since from New York, unfortunately, there were a lot of patients, there were a lot of death, but now there are a lot of donors that are available in New York Blood Center who actually are donating plasma. I mean, they have to have the titers of at least 1:160 or above to be able to donate, and they have to be completely without symptoms, or at least 28 days since their diagnosis of COVID-19 disease.
Dr. Agrawal, I had a question about if you know anything about the protocol at the blood banks, because I have a friend who routinely donates blood, a few times a year. And do they, I mean, given the limited testing we have for COVID, only the really high risk and only a certain category of patients are tested. Is there a protocol at the blood banks that anybody who's donating blood is getting RT-PCR? And we also know it's falsely negative, the 30% it can be negative. Plus, when they're collecting the plasma, I know these patients are coming in knowing that they have recovered, but do they get a RT-PCR before they donate the plasma?
I'm not actually aware of that. Actually, blood RT-PCR positivity rates are very, very low. They are like in less than 10%. So doing the RT-PCR on blood is actually not very sensitive.
I didn't mean it blood, but in just patients like nasal swab. How are we knowing that these patients are not infectious anymore?
So they have to be negative for nasal swab ×2, and they have to have the antibodies against SARS-CoV-2 to be able to donate.
So if the IgG is negative, go ahead, Anita.
They actually test that's what I read somewhere, that they actually test the antibodies before taking blood.
The blood, and all of these blood actually go to a specific blood pool. It's called COVID convalescent plasma pool. It's not the part of the regular plasma donation.
Mm-hmm.
But I can add to that too. So the FDA mandates that you should be 28 days asymptomatic without a fever. That would at least kind of prove that you don't have the disease. Or if you're less than that, 14 days, then you should get the PCR to show that you're negative, because it can be otherwise transmitted. So as far as the anti-testing is concerned, it would be, the ideal situation is to get the antibody testing, but the FDA has made a provision that if it can't be tested and it's urgently needed, you can save a sample for testing later.
So question, Nausheen, so I think what Nidhi wanted to ask her, like right now, if anybody goes to a blood bank, are they testing them for the antibodies for COVID, or they are just taking the blood right now? How are they, not for convalescent plasma, for any kind of blood? What are they doing?
For the regular blood donations.
Yeah, what I've seen in my institution or the places is that we don't routinely test, because there's not enough tests to test everybody. there's definitely a shortage of donors that are coming in, but based on screening, symptom screening is what we're doing. I'm sure different institutions are different, but generally at this point in time, there's just not enough tests to even test symptomatic patients at times.
So is there a potential risk of, having asymptomatic patients donating blood to the regular blood bank?
No, actually, now they're not really testing for antibody titers in regular patients who are donating blood. I think they're just going by the symptom check at this time. And patients or people who want to donate for COVID convalescent plasma pool, I mean, they have to have the documentation of COVID-19 disease and completely negative and completely recovered, and have to have the antibody test done. At this time, everybody's pretty much getting antibody test. I mean, there are enough plasma donation that nobody's requiring an urgent plasma donation. There is a lot of plasma pool in New York Blood Center specifically.
So just a quick question regarding that is, plasmapheresis has been done for, many other treatments. And, we talk about giving plasmapheresis, convalescent plasma, only in critically ill patients. Is there, could you walk us through the severity of the side effects? Why couldn't this be used a little bit earlier on if there's a better window where the patient doesn't have to go into multi-organ failure to get this treatment?
So donation, it's like blood transfusion or plasma transfusion. You have to be aware of potential risk of any plasma infusion, right? It contains donor lymphos. It should not contain any cellular, elements.
Yeah.
But by itself, there is a risk of transfusion reaction. There is a risk of anaphylactic reaction. There is a risk of possible transmission of other diseases. So, and it's a human blood product. So one has to be really, really careful about giving a plasma to these patients. And I think, I'm not really sure. I'm sure they're doing very good screening, but there is always a chance of transmitting disease when you're donating somebody's plasma at an urgent, basis. So I would still say it's a human product. One has to be careful and completely justifiable to give plasma to someone else.
And then, so to add to that, again, we have to understand that we don't know of the benefit yet.
Right.
We know, the FDA
theoretically, it should.
Yeah. Theoretically, it should, but that's what these studies, which have been done on like 5 and 20 patients, just 3-4 studies out there. It's trying to establish that there's no adverse effect from it, and there should be a potential benefit from it. And of course, so we're right at that stage right now. If we knew that there was a definite benefit, once we establish that, I think early on it can start being used, but not at this point in time. There's a potential, of course, there's a big potential for this.
Can you also comment on the plasmapheresis part, IVIG? I know that, some data coming. I know ASH is still not recommending any of these therapies, but just studies on it. But can you comment, Nausheen, on it?
So we talked a lot about convalescent plasma therapy, which is basically passive immunity. So the other thing which we have, you might be hearing these terms going around, hyperimmunoglobulins and things like that. Hyperimmunoglobulin to me is the same. They're just taking convalescent plasma and either purifying that product and making like a hyperimmunoglobulin product. IVIG therapy, especially high-dose IVIG, I think there's one study that's out there on 3 patients where they use a 25-gram for 5 days, and they show improvement on the 6th day and above. The theory is that, first of all, it's all just polyclonal antibodies that are there. So if that population that has donated the plasma, if they were exposed to COVID and had the antibodies, and that would, in theory, help. But the other part that in high dose IVIG, it could have an immunomodulatory effect. It could reduce the levels of IL-6. It could somehow, calm down the immune system. So that's a theory behind it. Again, there's a dire shortage of IVIG. I don't see that this is going to be something people are very excited about at this point. So that's my take on that. And then the last thing that we were talking about was therapeutic plasma exchange, which is actually plasmapheresis. I mean, taking the patient, putting a central line in and pheresing the patient, taking out almost the whole volume of plasma and replacing it with with either other plasma or plasma substitute. So that the theory behind that is you want to remove the cytokines, you want to remove the inflammatory cytokines and all that kind of purify the body. This is the same principle that's been applied for TTP and for other autoimmune diseases, hematological diseases. Again, it has not been done in COVID patients. It's been done in influenza, and I think they've shown that it helped in very, very small numbers. But it is a very invasive procedure. I don't know. We don't have any studies on it. I don't have any data on it at all.
And I think also the other reason is, it would need a lot of blood product, and we already are short of blood products compared to sickle cell patients. If they have COVID, it's like such a difficult. So and without any data, that's something that we don't want to. But I know there are, ASH is thinking about it. There's some, discussion about it. I don't think so there is anything we are doing right now. So that's out of picture. Probably the closest we are is the convalescent plasma, but
yeah, I agree with you. I think convalescent plasma probably makes more sense. Yes. And with high dose of IVIG, you also have to realize that it's not without side effects. We use IVIG in various treatments, ITP and hemolytic anemia, but it can cause aseptic meningitis. It can cause volume changes. It can also cause renal insufficiencies and renal damage in patients who already have multi-organ failure. You have to be careful about using so much volume and so much, osmotic volume for these patients. There are some other interesting treatment hematologically which may, modify the immune system, and the studies are actually ongoing. So one of them is JAK2 inhibitor. Jakafi is actually being studied for immune-mediated effects of COVID, and there is a phase 2 trial going on with Jakafi. And the other one is Solaris. So, it is basically complement inhibitor, and some of the, manifestations of immune stimulation with COVID could be complement activation, and they're trying to study Solaris in these patients in the situation.
Very
interesting. But in the interest of time. Yeah.
Thank you so much.
I know. I used to say to Nidhi, there's nothing I can contribute as a hematologist in COVID, and now suddenly we have a lot more to talk about. So very interesting. Thank you. Yeah. Go ahead, Nidhi, take it over.
Well, I did want to loop in Dr. Gudapati regarding the cardiac complications and cardiac patients being treated for COVID disease. Dr. Gudapati, are you here?
Yes, he's here.
Yeah, I mean, we had our hospital had the third case in the country, and we were expecting a surge, but that never happened. And we're not seeing as many cases as some of my colleagues in San Jose are seeing. So, I mean, for me, from reviewing literature, I think it's a sideshow. I mean, maybe how many of you guys are checking troponins or getting echoes on these patients? So, I mean,
in prior discussions, I think troponins were being checked, at least in the ER. With shortness of breath and you have a history of hypertension, I think a troponin does go out. And it was being reported mildly elevated. The question was, is there a viral myocarditis? Is there a real ischemic disease? Is there a role for early anticoagulation versus going to the cath lab,
So, I mean, from reviewing these 2 papers in JAMA Cardiology that came in, they said like 20% of the people have elevated troponins.
Right.
And then, obviously, like along with D-dimer and other inflammatory markers, they say it correlates well with the severity of the disease. And as the disease progresses, this troponin continue to rise, and it's much higher among non-survivors compared to survivors. I mean, the whole thing is does it matter? Okay, I mean, how much of them develop cardiomyopathy, and how much of them go into cardiogenic shock or circulatory failure, right? There's several mechanisms for this. One is most oftentimes, any sick patient, we see type 2 myocardial infarction, where these people are profoundly hypoxic and in shock, and there's some troponin leakage, right? And also the other thing is any inflammatory condition, people are predisposed to acute coronary syndrome from plaque rupture. And then, the other thing is the microvascular thrombosis, which you guys are talking about from DIC and such. Then, the other thing they talk about is the dysregulated renin-angiotensin system. When this virus binds to the ACE2 inhibitor and there's downregulation of this receptors, and then there is more angiotensin 2 activity. And then the last thing, which is probably what is of interest, is myocarditis, right? When we see myocarditis in any inflammatory condition, recently we had a patient with H1N1 who had fulminant myocarditis, and within 3 days, he went into profound cardiogenic shock, and we were trying to get him onto a VA ECMO. He didn't make it. So the only question is, how many of these patients with COVID have fulminant myocarditis? We have seen these two or three case reports that came in with ST elevation, and they did an angiogram on this. No coronary artery disease. Some of them were put on mechanical support, and they were given steroids, and they made it. The question is then also, what's causing the myocarditis? Is this the viral damage, or this is an inflammatory response? It's like some immune myocarditis. At least based on the MRI, at least there is some component. You've seen this cardiac MRs, which showed that there's all this enhancement. So I was looking for any autopsy studies. There were none to see if there are any viral RNA in any of these specimens. They're not, I couldn't find anything. And also I was trying to see if any of these patients had echocardiograms, what percentage of them have echocardiogram. You see this papers being published that they have significant cardiac dysfunction. So I was trying, a lot of them did not have echoes, which is appropriate. You don't want to expose your technicians to this patients when it's not going to help you. Why get an echocardiogram? So a lot of this is based on looking at the pro-BNP. And if the BNP goes up, they're assuming these people have significant cardiac dysfunction. The question is, a lot of them will have right heart failure due to, maybe right heart strain because of pulmonary hypertension. They have kidney failure, multi-organ failure, BNP is going to be high. Whether is that a true marker of cardiac dysfunction? I don't know. And then you guys probably have the critical care people in San Jose have a lot more experience. Are you guys seeing more any patients with circulatory failure and cardiogenic shock?
Dr. Singh, Dr. Murthy, anybody?
Dr. Subramaniam?
No, not clinically.
Yeah.
But yeah, the literature does support.
Yeah. I saw a couple of papers. One from Seattle. They said a third of them had cardiomyopathy based on. Some of them had echo. Some of them had they measured mixed venous or no, not mixed venous, central venous oxygen sat, and then based on that they claim that these patients have cardiac dysfunction. But then you look at the Seattle paper in New England Journal of Medicine. There was only a handful of them had echoes. None of them had significant cardiomyopathy. But I think, fulminant myocarditis, circulatory failure, it's still a rarity. So, and then today there was ACC, there was a review on this. Some of these patients come with plaque rupture and STEMI. In fact, we had a patient a few weeks ago who was COVID positive in the ER, sent home, came a week later with an acute MI, had a stent in his, had a thrombus in LAD that was fixed. But, now they're recommending thrombolytics for these patients, not for these patients, any patients with STEMI. That's supposedly the Chinese approach. These days, during this pandemic, anybody with any patient coming with ST elevation MI should get thrombolytics. But I kind of don't. I would still, unless this patient is presenting late, or if there's a unquestionable STEMI, I would take them to the cath lab. I mean, uh, taking appropriate precautions. So, I mean, I just, there's, if you look at the ACC review article that came up, still they are recommending STEMI, at least in stable patients. But if there's any hemodynamic instability, they're recommending taking to the cath lab. Even for routine troponin elevations, unless there is echo showing wall motion abnormalities and there is hemodynamic instability, then they're recommending doing taking these people to the cardiac cath lab. So we are taking a backstage in this, and yeah, I mean, so what's your what's your experience in terms of, I mean, are you guys are your cardiologists taking this patient to the cath lab or giving lytics?
I think
I think this is one of those rare scenarios where cardiologists are taking a back seat. So it's a moment in history.
Yeah.
Is this more of a demand ischemia kind of picture, or
right?
You right?
Yeah, I think I agree. I agree with his observations. I mean, I think the troponin is much more of a prognostic marker at this point. We're not really, our cardiologists are and us as intensivists are not looking to it to trigger any kind of decision making with regards to more aggressive cardiology interventions. The patients where there is persistent elevation or a steady increase in troponin levels early on in the course of the illness, I mean, some of them have almost 80-90% mortality. So it's a very bad prognostic marker, but at the same time, a very useful one. So that is, to me, really the most important role. Certainly, if they go into if once they go on the vent and if they are in shock, then an echocardiogram along with other parameters like non-invasive cardiac output monitoring with a Nikon are helpful in assessing their volume status, or bedside ultrasound may also be helpful in those situations. So mostly it's sort of the age-old argument, or is the patient wet or dry, and that kind of a thing, but not in any way trying to get them to a cath lab or do any kind of intervention on them.
Thank you so much. I'm just going to quickly ask few of the questions that the chat box has. Can any of the panelists comment on the pediatric population with COVID, specifically those cases that are more severe? Are you guys seeing any peds patient in ICU? Any of you would know anything, or any pediatricians in the group? I think I'm gonna pass this. Dr. Indu Gupta is here, but it looks like I'll have to pass this question unless somebody wants to take this question about the peds population with COVID. Okay, next question is, with more recent data, does use of high flow oxygen, even though risk for aerosolization early on, prevent intubation in some patients? Is there any data, Dr. Subramaniam?
Yes, I think we've sort of gone through a little bit of a change with this. Initially, about a month ago, there was this concern for aerosolization and exposure. And so there was a little bit of a move away from using BiPAP and high flow oxygen. But now, I think especially in situations like New York City, where you have the shortage of ventilators and things like that, we are realizing that may not necessarily be a more practical approach, that if we end up doing early intubation in everybody, then we are very quickly going to end up with a resource crunch as far as ventilators are concerned. And also there is this understanding that we may actually be doing more harm by ventilator-associated lung injury. So we are sort of now going back a little bit and dialing back that kind of mindset of trying to be aggressive with early intubation and actually saying, let's not jump the gun. There is enough precautions we can take with use of high flow oxygen, like they recommend putting a hood or a mask on top of the of the airvo or high flow oxygen cannula, and also making sure that we cover any of the exhalation ports with filters to make sure that we minimize exposure to healthcare workers with aerosolization. And also likewise the use of BiPAP. It's not a complete no. You know, there's some schools of thought that say, oh, absolutely should not use BiPAP, and I don't think that is necessarily what we want to be conveying to everyone. I think there certainly is a role. Just make sure that, I mean, understand that these are potentially procedures that can promote aerosolization, and just be careful, you know, either use a negative pressure room, make sure there's adequate PPE for staff entering the room, and make sure you have filters in place. But I would definitely be in favor of not universally just moving to early intubation in these patients.
Thank you so much. I think it's almost gonna be 8 now. Just looks like this week, the only promising therapy we have is the convalescent plasma, and probably something that we should look into. Nidhi, do you want to add a little bit about the testing, the antibody testing, or anybody wants to just add quick lines about the antibody testing? Are we doing it? The ELISA, IgG, IgM testing, are we still waiting for it? Because it makes complete sense to most of us, especially those healthcare providers who are exposed to it or continuously being exposed to it. If we have IgG, at least it's safer for us to go back to work, especially those ER physicians and pulmonary critical care. What do you think of this? Are we doing it?
I think your question is, I mean, we have the test. The question is, are we getting enough of it or not? Is it going to be accessible to, I mean, I completely agree with you. I think, and I did hear Governor Gavin Newsom announcing in the next week or two that there's a company that's going to be releasing a rapid 2 test, one of them is a rapid antibody test. And Stanford also announced that they are coming up with a test, and they're collaborating, I think, with Kaiser, but this is all the information that's on social platform, you know? Yeah. So, I mean, I think there is a role for antibody testing. The question is, just like the RT-PCR testing, why aren't we getting more of it? Why are we not getting enough of it accessible to everybody? Unless if any of the hematologists want to add on to it.
No, of course we need more.
Yeah.
We need more of these. I mean, the only place right now that I've heard of that also on social media is Mount Sinai, where they do antibody and PCR testing. Very rapid turnaround. They have an in-house testing. That's in New York, but I mean,
we need it. We need it now.
We need it right now. Yeah.
Because it's like, you know, even for the economy, it makes complete sense. Trump keeps on saying all these things about, okay, we have to go back to work. But if you are again going back to work and then getting back sick, and then, you know, it's a cycle. It's safer if we know that we are IgG positive and IgM negative. At least, you know, we know we are safer and we can go back to work without worrying about, okay, what next? And also, I do see in the social media, there's a lot of challenges with even physicians who are intubated and they are not able to get donors for them for the convalescent plasma. I just don't understand why it can't be simplified. We already have the registry for the COVID positive patients. Why they cannot get together? Okay, this COVID patient was diagnosed at this time. They are over that, and just do one more test, get them to the convalescent plasma group or the donor. It's just so simple. It's just when it comes to, you know, by what is going on in the, you know, in our situation, it's just can't.
I think, Anita, the other thing also important for the antibody testing is to find out what the reinfection rates are. You know, that would be the other important, you know, piece.
Do we know, is there a reinfection? Because whatever data I have read, there is no reinfection. That's what I know, and things keep changing, so I don't know. Please to help us understand, is there
Yeah, no, and that is true. As of now, they have not proved infection. It is probably just the prolonged infection period in those patients. I know that they did some study on the rhesus monkeys where they had 5 monkeys and infected them with the COVID. And then early on in like the first 5 days, they killed one and they found out what through the RT-PCR about the viral load. And it found that there was high viral load in various tissues in that monkey, and then they once the rest of the 4 recovered, they did some the antibody testing at day 14, 21, and 28, and then at day 28 there was from another a postmortem monkey, they found out that the RT-PCR and the virus was all negative in all the tissues. So that would be something interesting, that if at day 28, and which you did mention, Nosheen, at day 28 would be a good period, right, for the convalescent serum. And that's probably where that study came from, that they found that on day 28 and all the recovered monkeys, the RT-PCR was negative on every single tissue.
So there's in terms of reinfection, there is a more recent data coming out from South Korea that talks about a pretty high reinfection rate. I think they looked at like over 50 patients who had recovered and now are reinfected. And so that combined with the other thing that's kind of coming out is the fact that up to a third of them don't have detectable antibodies or antibody titers or neutralizing antibody titers of less than 500. Which are very, very low. So I think those two are sort of, this is more recent. And so I think that is a little bit concerning in terms of this, in terms of the context we are talking about, is it safe for people to get back to work and get themselves exposed? If those types of reinfection rates are, this is only one country, that is South Korea. But I think it's obviously too early for us in the US to know what kind of experience we are going to have.
Interesting.
Hey, Anita, this is Jincy. I just want to add one thing regarding the antibody testing. So Stanford is
also an hematologist. So go ahead, Jincy.
Yeah, so the Stanford is definitely rolling out the antibody testing. We also actually spoke to them to see if we could get it done. So the information that I received was in about 2 weeks they are actively doing that for all of their healthcare. I think just not doctors, nurses, everybody, to see who can go see. They're actively doing it. So I think that's something to look forward to.
At least that's more promising than, at least we should start with the healthcare workers.
They're definitely doing it. And we spoke to, our group spoke to the chief of pathology, I believe, and that was the information that we were given.
That's what was published. So I think once they roll it out to their physicians, and then if they can give the patent for commercial labs locally, I think there could be a rapid deployment, not only to Kaiser and other, but also to, private physicians can also use it for their asymptomatic carriers or mildly symptomatic patients. That would be really great. Yeah.
I mean, one quick caution about the reinfection rate. I think one has to look at which patient required an anti-inflammatory or, and immunosuppressants. So those are the patients who may not mount an antibody, response to the virus and may actually have a higher chances of reinfection. So it's something that we need to actually keep studying, looking out for. When it comes to antibody testing, I think the mass scale antibody testing can only be feasible really after the vaccine is available, because otherwise the utility of mass scale antibody testing is relatively low. I think here the antibody testing for patients who were suspected, to be infected with COVID are the one that probably should go ahead. And, we have to make sure that we are utilizing our healthcare resources properly. So I think that's where we should be testing antibody to see which person can go back to work and who are the potential convalescent plasma donors.
That's a very interesting point. You're right, because we are already limited in our resources. Making the best use of what we have is very important. Thank you so much, Dr. Agarwal. That's
okay. All right.
Yeah, very nicely done. Nidhi, you wanna?
I think I don't see many questions, and I, in the interest of time, I really thank everyone for joining us today. It was a great discussion. I learned a lot. I hope the audience also learned a lot. Thank you all for joining, really. And please be safe. And yeah.
Thank you.
Thank you.
Thank you.
Thank you. Good night, everyone.
Good night.
Good night.